Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today, we will discuss the end of the waivers and flexibilities associated with the COVID-19 public health emergency. You will find two PDF documents posted in the handout pane of the control panel. The slides for today's webinar, and PYA's End-of-PHE Compliance Checklist. Also, you will receive an email later today with a copy of the slides and the checklist and a recording of this webinar. You may submit questions during the webinar by typing a message into the question pane of the control panel. Our presenters will do their best to address these questions during the webinar. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any questions. We'll respond to these questions after the webinar by email. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Laura. Good morning, everyone, and thank you for joining us today on our webinar to introduce PYA's post-PHE waivers and flexibilities checklist. As you know, on January 30 of this year, the Biden administration announced its intent to end the COVID-19 public health emergency on May 11th. And on that date, we will end a public health emergency that will have lasted 1,196 days. And with the end of the PHE comes the end of most of the waivers and flexibilities afforded healthcare providers during the PHE. So our starting point for today's discussion is, what are those waivers and flexibilities? What's the source of truth on which we can rely to understand how the rules have changed during the PHE and what our, quote, new normal is going to look like as of May 12. So let's start at the beginning. On March 13th of 2020 is when CMS published its Section 1135 blanket waivers and flexibilities. Section 1135 of the Social Security Act gives the Secretary of HHS the authority to waive certain regulatory provisions during a declared public health emergency. Prior to COVID-19, these blanket waivers and flexibilities were used primarily for natural disasters. So following a hurricane that had impacted the healthcare infrastructure in a particular geographic region, the CMS would grant blanket waivers and flexibilities for that region for a limited duration of time. With COVID-19, this is our first example of using those waivers and flexibilities on a nationwide scale, and certainly the duration of 3 years for this PHE, dwarfs in comparison any prior PHEs that have been issued. But this March 13th action by CMS was sort of the standard set of waivers and flexibilities. In addition, this is where CMS began the process of expanding Medicare coverage for telehealth services based on the authority the agency had been given by Congress to waive a number of the restrictions we find in Section 1834M of the Social Security Act. A few days later, the Drug Enforcement Administration within the Department of Justice issued its waiver under the Controlled Substances Act. That legislation specifically gave DEA the authority during a public health emergency to permit the prescribing of controlled substances based on a telehealth visit only. Otherwise, the CSA requires any prescription for controlled substances to be based on a face-to-face encounter between the prescriber and the patient. Under the authority of the PHE, DEA has waived that requirement and permitted those prescriptions based solely on a telehealth encounter between the prescriber and the patient. At the end of the month, March 30, CMS then published its waiver of sanctions under the STAR clause, a separate authority This within Section 1877 of the Social Security Act affords CMS discretion in how it enforces Stark law, how it imposes sanctions. On March 30, CMS outlined what are referred to now as the Stark waivers, which permit certain financial arrangements during the PHE without concern as to an application of a Stark waiver. Also on that same day, CMS published the first of 4 interim final rules. These were followed then by a rule on April 30, then August 26, then October 28. These rules actually went in and amended regulations to provide special accommodation during the public health emergency. Again, CMS also used these interim final rules to continue developing out the broader coverage for telehealth services. Several months later then, in November of 20, CMS published its acute hospital care at home waiver, not a blanket waiver. This was the first non-blanket waiver that was published by CMS, but this allowed hospitals to apply for a waiver of certain conditions of participation that then permitted them to furnish acute care services in patients' home and yet still receive full DRG payment for those services. On May 5th of 2021, based on legislation authorized by Congress, Medicare published a waiver to permit ground ambulances to be reimbursed for certain treatment in place services furnished by those ambulance providers. November 4th of 2021 brought us the interim final rule on vaccinations for healthcare workers. So that is sort of the end of the line in terms of formal regulatory action within the context of COVID-19. What we've seen then in this 3-year period is specific COVID-19 related provisions in the standard rulemaking processes that the agencies go through each year. So with the publication of the inpatient prospective payment system rule each year, the OPS rule, Medicare physician fee schedule, and the like, we've seen specific provisions that have been intended to afford greater flexibility to providers during COVID-19, or on the other side of the coin, impose specific requirements on providers during the PHE. We've also had notices of enforcement discretion from the Office of Civil Rights, the Office of Inspector General within HHS. Those notices of enforcement discretion have been specifically targeted to telehealth, both to permit the use of non-HIPAA compliant modalities to deliver telehealth services, and the permission to waive copays and deductibles for Medicare beneficiaries for telehealth and virtual services. And finally, the last on our long list have been a series of frequently asked questions and other guidance that have been published by the agencies, specifically targeting certain provider types as to what flexibilities are afforded and how those flexibilities apply in specific circumstances. For all of this, you see on the screen the source of truth, which is the CMS Waivers and Emergencies website. And here is where you'll find links to all of the documents we've just referenced. But here you see the challenge is as you begin contemplating unwinding these waivers and flexibilities, the first challenge is simply to identify all the waivers and flexibilities and appreciate that they are in fact waivers and flexibilities, because these have been in place for the most part for 3 years. They have become standard operating procedure. And so as a provider facing the end of the PHE, your first task is just to realize, what are we doing today, which is in fact in reliance on a waiver and flexibility that now is going to terminate on May 11th. Kathy, next slide, please.
And I'll jump in with that, Marty, and just say for many of your employees, life will be changing, because as the new employees, this is what they've always dealt with. So they're going to have to get used to a new world.
Exactly. Well, CMS is been issuing a series of guidance documents around the Great Unwind. That started back in August of last year. So before we knew the date of the end of the PHE, CMS posted a blog creating a roadmap for the end of the COVID-19 public health emergency, where leadership team at CMS acknowledged that we are coming near to the end of the PHE, that we'll have to unwind flexibilities on which we relied. And at that time, they published the first set of provider-specific fact sheets, which were intended to highlight, again, where the waivers and flexibilities have been in place and what will happen at the end of the PHE. Then shortly after the January 30 announcement of the May 11 end to the PHE, HHS published a fact sheet on the COVID-19 public health emergency transition roadmap. And again, at a very 20,000 foot level, provided an overview of how the unwind would proceed within the agency. Then on February 23rd, CMS re-released those provider-specific fact sheets that had been published back in August. It updated those fact sheets primarily to address provisions within the Consolidated Appropriations Act of 2023. And those stand still as the current version of those fact sheets. They are available on that website, the Waivers and Flexibilities website. There are, I think, 18 of them across all providers types. Then about 4 days later, CMS published its fact sheet, What Do I Need to Know? Or as we refer to it, What to Expect Now That You're Expecting the End of the PHE. But it, again, if the first document was the 20,000 foot level, this is the 10,000 foot level. It goes into greater detail in terms of the impact on reimbursement, the impact on telehealth, and some of the more significant waivers on which providers have relied. But again, not at the granular level which you're now facing as providers in terms of how are we going to actually unwind our operations. In the document accompanying the release of that fact sheet, CMS promised that it would be holding stakeholder calls and office hours to provide more specific information, that it would continue to update the emergency page with more and additional guidance. As an example of that more and additional guidance, on the March 2nd Skilled Nursing Facility Long-Term Care Open Door Forum, CMS officials did a little deeper dive into how, for example, the 3-day qualifying stay waiver would be implemented. And Kathy's going to talk more about that in particular, but appreciate a lot of these sort of common modes of communication between CMS and the industry now are going to be our source for additional guidance on how the unwind will move forward. Finally,
Martie, before you go on, let me jump in. I would urge you, if you are not listening to the open door forums, to get on the list for the hospital open door forum, the physician open door forum, etc. And in addition, and probably even more important, okay, for each of the open door forums, there is a mailbox where you can submit questions. There is a skilled nursing open door forum mailbox. There is a rural open door forum mailbox. If there are questions that we can't address, then what I would urge you to do is to go ahead and submit a question, because I will be honest and tell you, I submitted a question about 3 weeks ago related to the skilled nursing issue. And are we looking at admissions or discharges after May 11th? And they answered that it was the first thing that they did on the call. Now, I don't know if it was because of the question I submitted, but I'm glad I had submitted that question. And so I urge you, if you have specific issues that you need clarification from CMS, this is a way. There is always a transcript and a recording of these open door forums. So I urge you to submit your questions to CMS so that they could be specifically addressed on one of these calls.
Thank you, Kathy. The last document I want to draw your attention to is one published on March 10 from the Office of Inspector General. It is a notice that addresses how OIG's flexibilities will be unwound at the end of the PHE, specifically addressing their guidance on the waiver of co-pays and deductibles for telehealth and virtual services. That notice of enforcement discretion will terminate on May 11, and thus we will again be required under the Civil Money Penalties Act to bill patients for copays and deductibles. It also addresses the Stark Law waivers, making it, again, very clear that if you have entered into a financial arrangement in reliance on that Stark Law waiver, that those arrangements need to be brought into compliance by the May 11 date. And we, again, anticipate we'll see more of this sort of publications by the agencies addressing these specific issues. And as Kathy said, we need to lead the horse to water by, as an industry, asking the questions where we need guidance. Next slide. There are some things that are not impacted by the end of the PHE, and we want to call these out specifically. Beginning with FDA emergency use authorization for COVID-19 vaccines, tests, and treatments. The emergency use authorization will continue in place and will be transitioned per the Food and Drug Act statute, so it is not impacted by the PHE. Hospital and long-term care facilities, you know by regulation you have COVID-19 related reporting requirements. The term of the reporting requirements, the specific obligations, again, are subject of separate regulation. They are not impacted by the end of the PHE. The healthcare provider vaccine mandate, again, separate standing regulation, not impacted by the end of the PHE. OSHA's healthcare emergency temporary standard, which has handled a lot of issues in all kinds of workplaces, including healthcare workplaces. It remains in effect, although if you go to the OSHA website, it has a banner indicating that they are in the process of reevaluating the standard and anticipate that there will be changes, but to this point, none have been made yet. And again, not tied to the end of the PHE. And finally, providers' duties and obligations relating to their provider relief fund payments in terms of reporting requirements, single audit requirements, and don't forget those promises we made when we signed the acknowledgement form, when we first received those dollars. Those are going to remain in effect. Specifically, I'll reference to your obligation for a patient for whom you're providing treatment who has a case of COVID-19. You agreed in that acknowledgement form to treat that patient as in-network and not charge them out-of-network costs. Remember, that predated the No Surprises Act and the obligations we have under that statute, but that is a separate obligation under the Provider Relief Fund, not impacted by the end of the PHE. Next slide.
Sure. Just a little bit about the checklist that we have put in the handout section. This is something that you might want to refer back and forth to as we go through this. If you have two screens, be able to pull it up. But this checklist, without check marks, but this checklist does provide, is organized by provider type. There are certain issues that are applicable to all providers. We've identified those, but then other than that, organized by provider type, so you can look at those things impacting physicians, hospitals, post-acute care facilities, etc. So they are all identified on the checklist. This is not what was the waiver. This is what do I have to do on May 12th. We're not telling you what was waived. We're telling you what you need to have in place on May 12th to be in compliance. Recognize that in terms of this checklist, we are not looking at those waivers and flexibilities that have already been terminated or those that were made permanent. Also, issues related to reimbursement for COVID-19 vaccinations, testing, and treatment. We haven't touched on that. Any value-based purchasing programs, the requirements to report your data and what will be counted in the measures for value-based purchasing, hospital-acquired complications, etc. That is not addressed. Those will come out in rules that we will see later this year. Any Medicaid program waivers and flexibilities are not included, as well as those state and local waivers and flexibilities. Those are not addressed. This is more from a national perspective. Recognize also that this is a compliance checklist. It's not an instruction manual. It is certain items that you would be able to go in and to monitor, is the lab doing what they are now required to do, and to actually work from a compliance checklist perspective. There is a disclaimer on this that this does not constitute and cannot be relied upon as any form of professional or other advice. Although Martie is an attorney, this is not done from the legal perspective. It is merely looking at what are the rules.
And Kathy, we better acknowledge it right up front. It's 11 pages long.
Okay,
And it is as brief as we possibly could make it, because again, we're pulling from multiple sources to make sure that this is a comprehensive document. And so, yes, if you're just a hospital, your hospital section is about 4 pages long of that. But appreciate if you're a hospital that has a home health agency, that has a skilled nursing facility, that has a laboratory, there are other sections you're going to need to reference to identify there's a specific issue that you'll need to be addressing as part of your undefined plan.
Thanks, Martie. In terms of, as we said, we arranged this based upon various provider types and issues. So I'm going to start off with those issues that impact everybody or have the potential to impact everyone. From a provider enrollment perspective, those as of January of 24, those providers who render telehealth from their home are going to have to include their home address on their Medicare enrollment. CMS is going to move forward with resuming normal application processing timeframes. So we're going to be back on the cycle that we were on previously. And from appeals perspective, all of the regulatory flexibilities that were in place during the public health emergency, extended timeframes, et cetera, those are all going to expire. COVID-19 diagnostic testing and reporting, I think the major issue there is that those providers, think physician office in particular, who will no longer be required to post your prices for COVID testing. However, hospitals, remember, you still have your price transparency requirements. Those continue to be in place. CMS will now defer to the states on issues regarding licensure. And from a fraud and abuse perspective, any of those arrangements that were allowed during the public health emergency that perhaps could hinge on a problem with the Stark Law, those must be brought into compliance with the Stark Law. If you and so recognize you need to identify those and move forward to get them corrected quickly.
And again, we're not intending to read the checklist to you. We're just trying to hit some of the highlights, some of those what we believe are the most impactful changes, but again, not the level of detail you're going to find with the checklist. So let's talk about telehealth briefly. In terms of reimbursement for telehealth services under the Medicare physician fee schedule, the good news is everything is going to stay as it is today until January 1st of 2025. That is the result of the congressional action in the Consolidated Appropriations Act of 2023. However, there are still some outstanding issues to be addressed by CMS, hopefully through the normal rulemaking process. That includes the expanded list of telehealth services. We went from about 100 approved telehealth services to over 200 through the course of the PHE. The question now is, how are those going to roll back? We know, at least for now, all the telehealth services will remain on the list through about mid-October, but we'll need CMS to come in and provide us additional direction as to the treatment of the entire list. We have a question regarding payment parity. CMS has been directing us to build telehealth services with a place of service as to where the provider would normally see the patient face-to-face and then include modifier 95. The advice from CMS, the direction from CMS in the last year's rulemaking was that we would go back to using the place of service telehealth, and we would eliminate the payment parity, i.e. the physician practice would be paid for telehealth services at the lower facility rate going forward. Right now, those practices are paid at the higher non-facility rate. Need some resolution from CMS on how that's going to move forward. we have the answer on the waiver of co-insurance. I apologize, I should have updated this. In fact, now we have the direction from OIG that its notice of enforcement action will terminate at the end of the PHE. The same is true with regard to the use of HIPAA compliant telehealth vendors, that the expectation from the Office of Civil Rights, the agency that enforces HIPAA, is that we will in fact be using HIPAA compliant technology for performing audio visual telehealth services. The other change that we're facing with the end of the PHE is that the DEA's authority to permit telehealth-based prescriptions of controlled substances expires at the end of the PHE. And thus, you would only be able to prescribe controlled substances if you had seen the patient face-to-face at some time prior to writing that prescription. On March 1, the Drug Enforcement Administration published a proposed rule to address this issue. That proposed rule is certainly proving to be controversial in that it would only permit a 30-day supply and then require a face-to-face visit, and it would not ever, it would prohibit prescribing a category 2 controlled substance via telehealth only. So note that the comment period for that rule closes March 31. You want to be heard on that particular issue. Next slide, please, Kathy.
Before I do that, and I don't know if this is better for this slide or the next one, but we do have a question. Can you comment on which of the changes are pertinent to remote patient monitoring, asynchronous care, not telehealth?
Yes, and it's an important distinction because CMS does not treat remote patient monitoring, chronic care management, principal care management, general behavioral health integration, that whole series of codes it refers to as care management codes, as well as the virtual check-in codes, those that they deem as virtual services and not telehealth services. What we're seeing is really some very minor changes. During the PHE, they had afforded flexibilities to provide those services to both new and established patients. As of the end of the PHE, it will go back to the rule that only established patients can receive those services and for the provider to be reimbursed. On this incredibly busy page, which we are not going to go into any level of detail on, this highlights the telehealth flexibilities beyond just the reimbursement under the Medicare physician fee schedule for services delivered via telehealth. Through the PHE, CMS expanded the use of telehealth for services that would otherwise require a face-to-face visit or had some frequency limitation as to the utilization of telehealth services. So this is a detailed list, again, reflected in the checklist. You'll want to review within your organization to say, hey, for example, we are a home dialysis provider, and we have been using telehealth to do our required patient visits. That has to be discontinued. You have to go back to face-to-face visits by May 12th. So this is, again, one of these checklists you're going to need to review carefully to figure out where have we changed our practices, and we're going to need to go back to face-to-face encounters. Next slide. For physicians and other practitioners, and so now we're getting into the sections of the checklist that are specific to particular types of providers. Note here, for the duration of the PHE, CMS has permitted direct supervision by a physician to be performed virtually. In last year's rulemaking, they agreed to extend that virtual supervision through December 31st of this year. We'll see what happens in 2024 rulemaking if there's any change. The flexibilities with regard to substitute billing arrangements, what old people like me still call locum tenens, they will reinstate the 60-day limitation on the ability of a provider acting as a locum tenens to bill under another provider's NPI. As I referenced previously, virtual services will go back to established patients only. And then there are a series of national coverage determinations and local coverage determinations which have been relaxed during the PHE with respect to certain clinical indications or frequencies of services. And those relaxations will tighten back up, and we'll be back to the letter of those NCDs and LCDs. Next slide.
I'm going to do the next slide, but we also have a question. So let me get to the question.
Okay.
Okay, and I'm just trying to figure out on the pane. Here we go. So the geographic and location limitations related to telehealth services did not apply to home dialysis. Can you comment on the previous slide regarding home dialysis? That was, okay.
Yeah,
Go
that's a
ahead.
great question because we need to make this distinction in the telehealth flexibilities. So when Congress came in and said, we're going to relax the geographic and location restrictions for telehealth, that concerned Medicare reimbursement for services delivered via telehealth under the Medicare physician fee schedule. What CMS did separately was create flexibilities within regulations that required certain face-to-face visits as a condition of coverage for different types of services, like home dialysis, for example, like home health services. And CMS came in and said, okay, for the duration of the PHE, rather than requiring there be a face-to-face visit as a condition of coverage, we'll permit that to be performed via telehealth. And so now, yes, the geographic and location restrictions have been waived through the end of 2024, but now CMS is saying, well, we permitted you to use telehealth in place of a face-to-face visit. We're now going back to the face-to-face requirement. So it's separate from that statutory authority under HE 34M, because this is a separate regulatory requirement where they've relaxed the rule to permit telehealth as opposed to face-to-face visits. There's
Okay.
also sorry. Kathy,
Go ahead. Go ahead.
That's all.
Okay, and I'm just trying to get into the questions because there are a number of them here. Matthew, you might want to tell, okay. Under the physician and other practitioners, so previous slide, discontinued billing CPT 99211, does that mean we will not be able to get paid for the nurse visit COVID testing?
You will not be
testing staff with symptoms?
We'll need to go back to the specific language of what CMS permitted for 99211. And again, that's why this is a checklist and not an instruction manual, that we're referring you back to the issue. But what has been permitted is for inquiry to the patient as to their symptomology and then collection of the specimen. Those actions by clinical staff have been reimbursed at 99211. What we'll do is simply go back to the prior requirements regarding billing of that particular code.
And then there's
whatever
also
would satisfy that previous is now satisfy that code.
And there's also a question. Oh, I'm sorry, Marty. It's hard to tell when we aren't on camera. Provider address on enrollment. If part of a group, it would be updated on the 855B. Does the provider's address need to be populated on the CMS 1500 claim, or is the request only to place this on the enrollment? The issue of the claim is wherever the service was provided is what you are putting on the claim. But from an enrollment perspective, if the address is not a part of the enrollment file, the address you put on the claim, if it's not a part of your enrollment file, the claim is not going to process at the end of the PHE. We also have a question, if not a Medicare provider, what would the requirements be? We are looking requirements for the telehealth. You're going to have to look at individual payers at that point. This is the Medicare waivers that have been issued.
Okay, let's move on to hospitals, because again, if you look at the checklist, this is the most significant chunk in terms of the waivers and flexibilities that have been afforded, and now will be the most significant work on the back. The hospital waivers and flexibilities fell into three categories. Those that were intended to expand physical capacity, give you more space to take care of patients. Those that were intended to expand workforce capacity, so let certain providers, certain staff deliver a broader range of services, and those that were intended to reduce administrative burden, sort of free up your time to focus more on patient care. Again, there are a number of waivers under each of these categories, just to highlight some key provisions. If you expanded the locations in which you deliver inpatient services, so you converted conference rooms to patient beds, for example, by the end of the PHE, you need to roll back to the normally recognized areas of the facility in which inpatient services are provided. Off-site EMTALA screenings. We go back to the rule that medical screening examinations must be performed in the hospital emergency department. Creating new or relocating existing hospital outpatient departments. Again, unless you've gone through the formal process of identifying that space as an HOPD, we roll back. Of particular importance here is the flexibility that permitted hospitals to designate the patient home as the hospital outpatient department. That discontinues. So to the extent that you've been delivering services in the patient home, like infusion or wound care, sending staff to the patient home to deliver those services, or you've had clinical staff furnishing certain services like partial hospitalization services virtually, those are going to no longer qualify for reimbursement because those locations are no longer considered hospital outpatient departments. The exception there, pay attention to the 2023 OPS rule, which provided new OPPS reimbursement for certain behavioral health services, certain education services delivered virtually by hospital staff. So not separately reimbursed with the fee schedule, this is hospital staff created reimbursement under OPPS for those services. SNF qualifying 3-day stay, we previewed this previously in this presentation. Prior to the PHE, a patient could have a covered SNF stay, i.e. Medicare would pay for that stay, only if that patient had spent at least 3 days in the hospital prior to that admission. That requirement was waived for the PHE. So for 3 years, we've been admitting patients to SNFs with greater frequency because we haven't had to, check the box. There having been a 3-day stay, that ends on May 12th. So Kathy, make sure you get this right. It's admissions to a SNF on May 12th or thereafter, correct?
That's correct.
Okay. So if you have a patient that was in a skilled stay that extended past May 12th, that stay would still be covered even if there had not been a qualifying 3-day stay. And then there's the acute hospital care at home waiver. You know that, again, Congress stepped in and extended this waiver, permitted that program to continue through December of 2024. On expanding workforce capacity, there have been waivers that have provided flexibility in medical staff credentialing and privileging, so relaxation of those conditions of participation. Your medical staff office needs to go back to the way it was doing things before the PHE, effective May 12th. Requiring that all patients be under a care of a physician. This has afforded flexibility that some patients could be admitted under the care of a non-physician practitioner. Again, for PBS hospitals, the rule goes back to physician only. And then a relaxation of the CRNA supervision requirements. Also, we'll see that roll back, and you'll go back, again, having the anesthesiologist levels of supervision that would fit in place pre-PHE. Finally, on the category of reducing administrative burden, there's been relaxation of the conditions of participation around quality assurance and performance improvement programs, as well as utilization review. For those in your hospital that are responsible for those functions, they need to go back to the source documents and ensure that those programs have again been expanded out more fully to address the full range of issues within the hospital. And finally, the authentication of verbal orders, the reliance on standard set order sets and the like. Again, the flexibilities terminate in those areas as well.
And Martie, we have some additional questions, but what I'm going to do is go ahead and let's keep going, and then we can get to those questions shortly. Okay. So teaching hospitals and teaching physicians, Martie touched earlier on the issue related to the teaching physicians and residency programs located outside of a metropolitan statistical area, an MSA, are the only ones who can meet the presence requirements for key services required by telehealth. So again, this is where we get into looking from this checklist across different types of looking at telehealth to find out what are the rules then related to teaching hospitals. So it'll appear in multiple places. But the main point I wanted to make on the teaching hospital issue is that after the end of the public health emergency, we start getting into issues related to counting of residents for direct graduate medical education and indirect medical education payments, and claiming residents who have been sent to other hospitals, things like this. That is going to impact your residency counts, and it could impact your overall Medicare reimbursement going forward. Critical access hospitals, Martie? And we have a question on that one. Please comment on the 96-hour length of stay for cause. We have
I would love to. Note, just one thing is, before we go to these specific critical access hospital requirements, note on the checklist that in the hospital section, there are certain items that have an asterisk by them. Those mean that those apply to critical access hospitals as well as PPS hospitals. So if no asterisk only applies to a PPS, those with asterisks also apply to cause. If you expanded your capacity as a CAW and using more than 25 beds, you go back to the 25 bed requirement. We have been directed that we will have to adhere to the 96-hour length of stay requirements. Talk about an area where we need some guidance from CMS is how they intend to implement this going forward, because it's been waived for such a period of time. How are they going to calculate compliance with the 96-hour rule? There's the World Open Door Forum. Again, as Kathy noted, there's a mailbox. You can submit the question. We certainly need to alert CMS to the need for guidance around the 96-hour rule requirement. If you've used any off-site locations, again, to expand capacity to meet the surge requirements, if that new site does not meet the requirements for a rural location or distance to another facility, you'll need to bring that back online. Kathy, I think we popped forward a slide. Thank you. We go back to the requirement that there be an MD or a DO must be physically present at the facility for a sufficient period of time to provide medical direction, consultation, and supervision. During the PHE, we were allowed to use virtual presence to meet this requirement, but it goes back to physical presence on May 12. And then there are a series of minimum personnel qualifications with regard to non-physician practitioners that have been relaxed during the PHE. Those will go back into effect for the critical access hospitals again at the end of the PHE. Next up, Kathy.
Sure. Maybe. There we go.
There we go.
For issues related to long-term care facilities, particularly I'm going to focus on skilled nursing facilities. Martie addressed the 3-day rule under the hospital section, and that we would be looking at those patients who were admitted on or after May 12th in terms of whether or not they had that 3-day consecutive stay prior to admission. It doesn't have to be right before, but it usually would be termed within a 30-day period prior to the admission. The other thing that CMS did clarify on the skilled nursing open door forum related to the interrupted stay policy as it relates to the end of the public health emergency. If you have a patient who was admitted prior to May 12th and did not have a prior 3-day hospital stay, they leave the skilled nursing facility for less than for 3 days or less, and then return back to the same skilled nursing facility. They are covered under the waiver for the interrupted stay period, because they were not required to have a 3-day qualifying stay when they were originally admitted. Now, if they leave the skilled nursing facility after May 12th, they did not have a prior 3-day stay because they were originally admitted before the end of the PHE. They now have left. They are gone for a period longer than 3 days, or they are gone and returned to a different skilled nursing facility. They are going to be required to have a 3-day qualifying stay. So when we look at the interrupted stay policy under a skilled nursing facility, you really need to be looking at when were they originally admitted, and then did they come back within 3 days, and did they come back to the same facility? So that will be an issue as well in terms of looking at that 3-day qualifying stay. The other issues that we have included on here, one I wanted to call your attention to is making sure that you are appropriately dealing with your patients when it comes to choice from a roommate perspective or for sharing rooms or being moved within the facility. So make sure that you look at that. Home health agencies, the main point I wanted.
Kathy?
Oh, yeah.
I tried to do. There were a slew of waivers and flexibilities applicable to long-term care facilities that terminated last year. CMS came out and said, now we're done with these. We're going to go back to normal operations. And as you noted at the top, the checklist does not include any waivers and flexibilities that were terminated or made permanent prior to the beginning of the year. So this is one area, if you look at the SNF list, it seems really short because there's not much left after what CMS did.
Let's go on then to home health agencies. Wanted to make sure that I pointed out one main issue on this, on the checklist related to home health. And I'm doing this quickly so that hopefully we can get to some of your specific questions. But the second bullet about by the end of September of this year, any postponed annual on-site visits by the RN to the location where the patient is receiving care must be completed. So this is, as you're looking at staffing and scheduling, et cetera, recognize that there is a short window because it will come up very quickly that we do have to make sure that those on-site visits are completed by the end of September. Okay, here we go with the cursor. From a hospice perspective, again, the same issue, those on-site visits by an RN must be completed by the end of September of this year. One thing that we have had, particularly from a hospice perspective, concerns with COVID and transmission. We really have not had the focus on using volunteers that we have had in the past, but they will be reinstating by the end of this year that you are going to have to resume the use of volunteers for at least 5% of your patient care hours. This is an issue that I would think from a hospice care provider perspective, if you are having issues with getting volunteers, again, because of concerns related to potential infection, I would urge you to raise this as a part of the hospice rule that is going to be issued. Well, later this summer, there will be a hospice rule for 2024. I would urge you to comment on this because perhaps this is something that needs to be modified or maintained as a phase-in for a period of time, just in terms of getting those volunteers available. Martie, RHCs and FQHCs?
Okay. Matthew, if you could put just one slide forward, that'd be great. For RHCs and FQHCs, and again, they're very different types of facilities that rules apply. Back one, please. The most important change is going to be the reinstatement of the requirement that a non-physician practitioner must be available to furnish patient care services at least 50% of the time that the RHC FQHC is operating. We also have reinstated the requirement that nurse practitioners must be supervised by the RHC or FQHC medical director. Again, if you've had locations that you used for expanded capacity during the PHE, your continuation of those facilities are going to depend, again, on compliance with the established rules with regard to location, as well as certification and survey restrictions. And then there are certain changes that have been made to the billing for virtual communication services for RHCs and FQHCs as well. So these are specific rollbacks applicable only to our RHCs and FQHCs. Finally, last but not least, excuse me, are all the other providers who are impacted by the end of the PHE. One more slide, please. And here simply is the list of those providers, each of which are addressed in the spreadsheet, generally very specific changes to these rules that will impact these types of providers. Again, if your organization encompasses these provider types, be sure to review them as well. So a quick and dirty through the highlights of the checklist. We have about 10 minutes left here. We're going to do our best to swing at some of these questions you have for us. As Laura noted at the beginning, to the extent we don't get to your question, or if you submit it after the webinar using the survey tool, we will do our best to respond to those in a timely manner via email. I know I have a couple of outstanding questions from the last webinar. If you were one of those folks who posed those questions, we'll get to them as soon as we can. But Kathy, I'm going to turn it over to you to be our question MC.
All right. How do you count the 60 days for the locum? Is it per year or career?
It's per period of time, as I understand it. Again, another example of checklist, not instruction manual. You'll go back to the former rule in terms of limitation of service under locum tenens and how long they can operate under another provider's MPI.
Okay. And I think this next one is going to be the same answer. It is going to be the, you go back to what was originally required, but for hospice face-to-face assessments, do we need documented justification, such as staffing, infection control, et cetera, to continue these assessments via telehealth between May 2023 and December 2024?
Okay. Again, this is the distinction between the rules applicable to reimbursement under the Medicare physician fee schedule versus a separate regulatory flexibility afforded by CMS for the duration of the PHE that permitted you to deliver a service via telehealth that otherwise would be required to be a face-to-face visit. So those rules are not impacted by the action Congress took with respect to the coverage under the fee schedule. The exception to that is the Congress continued the use of telehealth for certain purposes for hospice recertification and certain home health required visits. Those are permitted to continue to be via telehealth, but otherwise, if you have a face-to-face visit, again, the example I used previously was home dialysis, that used to be delivered via telehealth, that goes back to being a face-to-face visit.
Please clarify the date when FaceTime Duo can no longer be used for patient visits. Also, audio-only visit parity stays till 1/1/2025, correct?
Yes, we will. What has been permitted to be a audio-only telehealth visit. So there's certain E&M, those identified audio-only E&M codes, as well as other specified services that can be delivered via audio only. That will remain the same. The issue regarding the modality that you're using, the technology you're using to deliver telehealth is one I'm not going to venture into, because it's a question of does or does not this particular modality satisfy HIPAA requirements. We are not in a position to pass judgment on any modality here. That will be a question for your IT team to address whether it meets HIPAA security rule requirements. But according to, let me make clear on that though. I didn't answer the end question, which was, when do we go back to requiring HIPAA compliant modalities? That's May 12th. Because that notice of enforcement discretion, OCR issued at the beginning of the PHE, they have said that terminates at the end of the PHE.
And I just pulled up the question again related to the 96-hour length of stay for cause, and you eloquently said that this is an issue that we really need to get discussion with CMS and congressional action. Martie, for some reason, I believe there actually has been legislation introduced this year. And why am I thinking it is either Kansas or Nebraska that senators have introduced it? So keep an eye out for that. For those who are concerned about that 96-hour length of stay and the inability to actually transfer, that, you know, urge passage of legislation that would extend that. The new end date for PHE telehealth for physician office is May 11th or 12/31/23.
One more time, Kathy, I want to make sure I got the question right.
is the new end date of PHE telehealth for physician offices May 11th, 2023 or 12/31/23?
So to the extent you're providing services under the Medicare physician fee schedule, and it's a service that is listed as a telehealth covered service, like an evaluation and management service, you can continue delivering that service via telehealth without regard to the location of the patient. So i.e. could be in the patient's home, doesn't have to be in a rural area. Those rules remain in place through December 31st, 2024.
So none of the above, 2024.
Yep.
What is the end of the telehealth services for outpatient PT, OT, and speech? And now those are paid under the physician fee schedule. So that would be the same, I would assume?
The Consolidated Appropriations Act extended the ability of PTs, OTs, and speech language pathologists to bill for telehealth services through the end of 2024. If it's delivered in a hospital, yeah. And so if it's the reimbursed service under the Medicare physician fee schedule, those remain in place as they are today.
Okay. Just a couple more. For hospice volunteers, compliance dated December 2023. What reference document did that come from? The provider specific document still has the end of the PHE. I don't think I have the hospice handy, but I believe it was in that most recent document.
Yeah, and it may be, make sure you're looking at the provider specific fact sheet that's dated February 23rd and not February 1st, because there were a number of changes between the two.
Yes, recognize that they keep publishing revised fact sheets, and that we will update the checklist if we find something that has changed. Can you clarify if telehealth visits will still be available for new patients in an outpatient setting?
So if it is a telehealth visit, so it's a visit that would otherwise, and remember CMS makes this distinction between telehealth and virtual services. Telehealth is when you use a communications technology to supplant what would otherwise be a face-to-face visit. And a virtual service is one that is by its very nature utilizes a communication technology. So if you're referring to an office visit, like I used to go to my doctor's office and I saw my doctor and I got billed a 99213 for example, there's no distinction between new and established patients. It's just the code will be different. You'll be paid a different code because it's a new or established patient, but it can still be delivered via telehealth until, again, the end of 2024. It's the virtual services, those other, specifically remote patient monitoring, some of the virtual check-ins where the established patient rule had been waived, and now it goes back into effect. So regardless, those patients that you're delivering those services for, it's only going to be covered if they're an established patient.
And Martie, I'm going to go on to the next slide, but just share with you that we do have a couple of people who have said thank you for the checklist and that they really like it. So what's next on the horizon?
Okay, so on Tuesday, March 28th, just over a little under 2 weeks from now, our evaluation team will be presenting physician compensation and fair market value topics relating to the end of the PHE. So this will be specific to changes and impacts on physician comp that arise to the PHE. Our team's going to do a deep dive on those issues. That's going to give Kathy and I a break from HCRR, but we will be back on April 12th when we're going to do one of our favorite things to do with HCRR. We call it reading the Medicare tea leaves, because we will have the new MedPAC report, and we will be on the verge of the rulemaking process for 2024. So Kathy and I will share our perspective in terms of what we see from a policy standpoint that's going to be driving those changes going forward. So we hope you'll be able to join us on April 12th. Again, apologize if we didn't get to your questions. We will follow up. If you now thought of a question you want to pose, please do the survey at the close of the webinar, and we will gather those questions and do our best to respond by email. But again, The version of the checklist you have is current as of today. We will update it as changes are made to these rules as we go through the great unwind. So I'm going to shoot it back to you, Laura, to take us home.
Thank you, and thanks to our presenters, Martie Ross and Kathy Reep. Later today, you will receive an email with their contact information, copies of the slide and the checklist, and a recording of the webinar. Also, the slides and recording for every episode of PYA's Healthcare Regulatory Roundup series, all 45 of them, are available on the highlights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and to post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.